Welcome everyone to the Hands-On Telehealth Interview Show. I'm Nirav Desai, and I'm very pleased to welcome as my guest today Debbie Voiles. Debbie is the Director for Telemedicine at the Texas Tech University Health Sciences Center. During her time here, Texas Tech Telemedicine has added 10 community-based sites to its network and grown consults by over 380%. Today, Debbie is here to share with us her insights on how they've grown their telemedicine program. So Debbie, I'm really thrilled to have you here. Thank you for being here.
Thank you for the opportunity to talk today.
Oh, thank you. Thanks so much. All right, so Debbie, one of the first things I love to ask people when we first get started is, what do you like to do outside of work?
Well, up until recently, it was chase my kids. But they're all,
Yeah.
yeah, they were all active in sports and everything up throughout high school and everything. But I've got two of them fixing to be in college, and so our downtime is changing, and now I'm going to start enjoying some me time. So,
Oh, cool. Very good.
trying to do a little bit of traveling and getting to see places that I want to see as opposed to where competitions are held at.
Oh, yeah. So primarily domestic, or are you planning on going outside of the country too?
Now, we're going to start domestic to begin with. There's enough places in the U.S. that we haven't been able to see that I want to see. So that's kind of what we're going to start with.
Very beautiful. It's good. There's so much to see in the U.S. It's amazing. So
Yes.
very diverse, actually. So okay, so tell us how you got started with telemedicine. I know you started a while back, so it'd be great to kind of get.
Yeah, actually, to start back what got me into it, I was going to graduate school. I had been in the oil and gas industry for a long time, and the company I was working for went out, sold out, and moved, and so I lost my job and thought, okay, what am I going to do? So I went back to graduate school, thought I was going to do finance, and decided that wasn't really what I wanted to do. And there was a program at Texas Tech for health organization management. And I thought, one of the things that's always going to be around is healthcare in some form or fashion. So I got involved in that program through while I was getting my master's. And one of the things I had to do was an internship.
Uh-huh.
And one of the offerings was telemedicine. Didn't know anything about it at the time. Did an internship. Just fell in love with what the concept that you could do with technology. They offered me a job at the end of my fellowship while I was finishing up graduate school, and I've been here ever since.
No kidding. Very cool. That's good. And so then when you started right after graduate school with that, then what did you, was it very familiar to you at that point since you'd already done your internship, or was it a real big challenge taking on the new role that you had?
I started out as the clinic coordinator, working with all of the docs and scheduling clinics and the patients. And at that time, we had we had 2 community sites and 15 correctional sites that we had going. And so the majority of the focus at that time was on correctional telemedicine, which is a great thing. Being able to provide services to the units and keeping the inmates where they need to be as opposed to out on the road traveling. So
Right.
there's a great benefit to the correctional. But in West Texas, we have 108 counties in our service territory, and there's a lot of open areas and people were not getting access to care. And so that was one of the things that I, started working on, is trying to figure out how we could expand out the community-based telemedicine. It was really slow coming because reimbursement was not very good in the early 2000s, and it's still it's still not where it needs to be, but it's a whole lot better.
And was that enough then? I mean, so reimbursement was not great, but you were still able to get people to support the telemedicine effort.
Yes, and we have really worked hard in Texas
Uh-huh.
to get Medicaid on board to reimburse for telemedicine, which we were one of the first states that Medicaid actually would do that. We also worked to get our insurance board to make it a requirement that anything billable face-to-face is billable through telemedicine. So, it's been a slow struggle, but it's going to be worth it in the long run.
Yeah, that's great. But then, so you were still able to grow the program, though, right? I mean, you got
Yes.
people to sign up and
Yes,
do it,
we did.
right?
And a lot of it was based on, we got a couple of different grants, which, as far as buying equipment and getting started, that's about the best economical way to be able to do that. And we've learned from that some communities can sustain the program and some are not able to. And so we've had a lot of good experience learning what works and what doesn't work.
Oh, that's interesting. So, and can you get into that a little bit? I mean, what, in terms of what works and what doesn't work with respect to grant funding and
Right.
things like that?
Yeah.
Yeah.
Having the grant funding to pay for the equipment is really good because, the equipment that we're using here at the Health Sciences Center that we ask the communities use, is really, we want everything is live interactive. We don't do any store and forward because it's not reimbursable in the state of Texas. And so when we look at a community, we have learned that you've got to go in and do a community assessment, talk to all of the leaders in the entire county and the community, county judges, the mayors, the superintendents of the schools, everybody in the community, because that's who's going to have to support it to keep it going after the funding for the grants runs out. And so, you've got to have buy-in from everybody that would use the equipment. Is one thing that we have learned for it to be sustainable. If a clinic wants it and they haven't convinced the community that it's a needed service or it's a benefit to them, it's not going to be a profitable, sustainable program in the long run.
So you're saying that the funding comes from the specific community that the telemedicine support services are going to be provided to. So it could be, if you're doing it for a town, then the mayor and some of the other politicians and other, people within the community have to help support it and then provide for the funding. Is that
Well,
right?
yes.
Or,
I mean, because ultimately, you're going to come and you're going to run across programs and communities that want to do telemedicine that there's not grant funding to be able to do this. But it would be a benefit to the community to keep the patients there locally as opposed to on the road traveling.
Right.
And so you've got to have buy-in from everyone to use the equipment so that the clinic can get reimbursed for providing services and having it. In Texas, through our Medicaid program, they can get reimbursed for a facility fee just like they do for Medicare. And so where it's not a lot, at least it's a little bit to help sustain the program, pay for the connectivity, and pay for the leasing of equipment and things like that.
Interesting. Okay. All right. So then what do you have to convince the people of when you're talking to them to say, hey, this is worthwhile. Let's do this for your community. What can you talk about the specific words or messages that you have to get over to them to convince them and bring them on board?
Well, a lot of it is, having them see what the financial benefit is. When you can keep a child in school and only have to be out of school for an hour for an appointment, just like they would if they lived in an urban setting, it's, they're in school, it helps the school, it helps the students. Parents are not having to take off work. If they're in most of these small communities that we go into, the parents are hourly paid employees, and most of them don't have leave time. So if they have to be away from work, they're not going to get paid. On top of that, if they have to travel, now they've got the travel expense to go along with not getting paid from their job to be able to take a family member or themselves to see a physician in another community.
Yeah. So then, go ahead.
So once they understand what the financial savings to them is, it's huge.
Right.
To the community in itself, the services are being rendered there. So if any lab work needs to be done, any kind of prescriptions need to be filled, all of that's going to be done locally now, as opposed to that money being spent in another community.
Right. Okay. And that is what helps convince the politicians and everybody else to,
Yes,
yeah, keep it all local as much as possible.
exactly.
Right. Okay. Very cool. Okay, great. And then, so let's talk about, since you grew this whole program, right? What do you, looking back now, what do you think are some of the biggest successes you've had? Maybe your top three.
Well, obviously, expanding the number of community sites that we have. I mean, that's where we're having a big impact um, on being able to provide those services to a lot of communities. As I mentioned before, in West Texas, our service territory is about 108 counties. It's about 49% of the landmass of Texas. Runs
How much?
8 hours.
Oh, what did you say?
8 hours. Yeah.
39%?
Oh,
Oh, 39%?
no, 49% of the landmass.
Wow.
But we only have 12% of the population. So we have patients in some areas that are having to travel 90 miles one way for primary care because there are no physicians in their communities.
Wow.
There's 22 counties in Texas that don't have a physician practicing in them, and there's 12 that don't have a physician, nurse practitioner, or a PA. And so this is, telemedicine can have a big impact on what we can do to provide healthcare services to these people
Mm-hmm.
without putting an undue burden on themselves or the system to pay for travel costs to travel into the urban settings to be able to
Right.
be seen. And it's not just a rural thing. We've got in El Paso, a city of 750,000. There are 7 dermatologists, and not one of them will take a Medicaid patient. And so the closest Medicaid dermatology providers are in Lubbock. And so for those Medicaid patients, they have to travel 6 hours. It's about 350 miles one way from El Paso to Lubbock
Oh,
to be seen. And if it's something that is just, a rash or something like that, that's not a life-threatening thing, I mean, that's a long ways to have to travel to see a doctor. And so where in Texas, reimbursement was focused on the rural setting, we have really worked with the Medicaid providers in El Paso to get them to waive that for pediatric patients. And so now every Thursday afternoon we have a dermatology clinic and see pediatric patients from El Paso. The cost savings to the system is anywhere from $500 to about $1,200, whether the patients drive or they fly. So it's huge, and those are the success stories that we like to talk about. Being able to save not only the patient's time but the system money in the long run.
yeah, that's very cool. So, and then do you feel like based on everything you've gotten to accomplish that you've gotten that return on investment from, everything you guys have put into it and the money that's brought in and everything, or?
It's not so much in our philosophy. It's not so much about return on investment, but about taking care of patients. Being part of a medical school, one of our missions through the medical school is to provide healthcare services to patients, whether they can afford it or not. And telemedicine just allows us that opportunity to expand out to regions that we wouldn't otherwise be able to reach those patients to provide those services.
Yeah, yeah, and it's that's absolutely terrific, right? Because it's so important to get that out there for everyone. And then, was there ever any kind of concern? I mean, I think that's great because it's a lot of academic medical centers do that kind of take that kind of approach. There are some, of course, that are still looking for that kind of economic approach. What would you say to them if they're any advice from your standpoint? Maybe why they should or shouldn't consider that.
Well, one of the things that we've looked at and we've studied is seeing a telemedicine patient is actually cheaper for the physician and his staff than it is face-to-face, because everything is done on the patient side as far as checking the patient in, doing the vitals. You're not tying up one of your consult room or clinic rooms, and so you're not using your supply. So in the long run, seeing a telemedicine patient from a physician's perspective is actually cheaper than it is to see one face-to-face.
Yeah.
And so, you get some economies of scale, the more patients that you see. As far as that goes, you're not tying up your clinic time. And so there's some cost savings there that kind of offset, what it is that we're trying to get them to do. They're getting paid exactly the same as if a patient walked in the front door. So, that's one of the things that we really work to try to educate our physicians here is, if you see a telemedicine patient, you're going to see this patient anyway, whether it's a face-to-face or a telemedicine. If you see them through telemedicine, you're actually going to be making a little bit more money because it's not costing you much on the clinic cost.
Oh, interesting. Wait, it's not costing them much on the what?
On the clinic side, in their own clinic.
So, because they don't have to use other staff to try to bring the patient in, admit them, do all those kinds of things.
Exactly.
Interesting. Oh, okay. And so they buy into that pretty easily with
some
that?
of them do. It's a challenge. I
Yeah.
mean, getting provider buy-in is probably the biggest challenge that we have. Some of them get it. Some of them just don't. Still, we're still struggling. We're really trying to work with the younger doctors as they go through medical school and do their residency to educate them on the benefits of telemedicine, not only for themselves but for their patients. And so we're hoping that as we work with the younger group that are so used to computer-based technology and playing video games and doing everything, electronically, that will broaden the amount of providers that we have to offer services for.
Right. So, and then what about you mentioned that, some are more receptive to it than others. Do you find within a specific set of clinical disciplines that it's more amenable versus others?
Yes. Ones that really have issues with wanting to have the hands-on experience that they can't do. If they do a lot of testing when a patient comes in, those are ones that we really have a challenge to try to get them to see the benefits of telemedicine. One of the areas that we struggle with is our pediatric neurologist, getting them, because they do such intense testing when a patient comes in that we can't replicate that, or we haven't figured out how to replicate some of that through the technology. So trying to get them, to buy into doing this, it has been a challenge.
Gotcha.
But we've got an adult neurologist that is doing this, and so we're hoping that through his experience that we can take that and work with our pediatric neurologist and show them that there are ways to be able to do this. Not every patient can be seen over telemedicine, obviously, and we recognize that. But if we can save, even 7 out of 10 patients from having to travel for some type of service, then it is a benefit in the long run.
Right. Because I guess I think of trying to sell telemedicine sometimes as, what is the other alternative if you don't do that, right? I mean, if that patient if you can't see that patient at all, versus if you can see them and do some things, isn't that better than being able to do nothing for them?
Oh, exactly. And that's one of the things that we try to work with them and tell them, if we don't see them over telemedicine, they're not going to be seen until they end up to the point where they're in the emergency room. And now, we've disadvantaged the patient because their health condition has deteriorated, but we've also added an undue burden on the system because it's gotten to the point where they've ended up having to go to the emergency room and be treated for a more expensive procedure that maybe could have overcome if we saw them sooner.
Yeah, and I imagine the argument from the physician standpoint is something like, well, if I can see them but not really be able to do the appropriate workup that I'm typically used to doing, then I might not be able to provide the appropriate diagnosis, and then I could make an error or whatever, that sets me up for liability.
Well, and a lot of times what we try to do in those cases is say, okay, fine, we understand, bring them in initially, do all your testing, but allow that patient to have all their follow-ups done telemedicine.
Yeah.
And for most cases, follow-ups are just reviewing labs, reviewing testing results, things like that. And so you're not going to have the need the hands-on for those kind of things, since it's just talking heads. And so working with them, trying to get them to understand that and agreeing to at least start with follow-ups has helped us a lot to get physician buy-in.
That's a great idea. Yeah, that's cool. And then what about, do you use mid-levels and other folks instead of physicians as well for any?
Right now, we don't. As far as what we're providing is all physician-based.
Uh-huh.
Up until recently, and it's still in the process of being approved at the Medicaid level here with HHSC, is being able to bill for a mid-level seeing a patient over telemedicine, because up until very recently, our medical board has dictated that it has to be a physician seeing the patient, and so we've tried to, follow those rules. They have since we've been working with them to try to get them to understand that there are other providers besides physicians that could see patients and provide a great benefit through telemedicine. And now we're just trying to get the reimbursement to go along with what those rule changes are.
Right, right. And so right now, is everyone you're covering, are they all Medicaid?
No, we see Medicaid, Medicare, private insurance, self-pay. If it's a self-pay patient, we find out from the provider what the cost will be. We let the patient know up front what the service is going to cost, which would be the same if they drove in and saw them face-to-face. So the savings to them is that they don't have to incur that travel cost, and so it's a big benefit even for self-pay patients.
Yeah, okay. Very cool. And then I didn't get to ask you this a bit earlier, but what clinical disciplines are you covering right now?
We are covering dermatology, endocrinology, pulmonology, urology, psychiatry, both adult and pediatric. We're doing some psychotherapy stuff. We've done some cardiology, neurology. We are just in the process of starting a new clinic in Abilene where we'll be seeing HIV patients. So we're adding infectious disease to our list. Genetics, and I think those are the big ones that we're doing right now.
That's interesting. So then, what was I thinking about that? So with all these different disciplines, are they all scheduled consults? None of them are like emergency on the spot consults.
We actually general pediatrics is the only one right now that we're doing on a non-scheduled basis. We've got a couple school-based health